Hello, this is Dr. David Best from the Doctor's Channel. I am pleased to have three nationally known thought leaders today in a roundtable discussing the current and emerging trends in DVT prophylaxis. First, we'll be discussing DVT PE epidemiology and burden of disease. From there, we'll have an interesting case study and risk assessment, appropriate prophylaxis, and a patient undergoing joint replacement surgery. Finally, we'll have a discussion of DVT prophylaxis with LOVENOX in hospitalized acutely ill medical patients.
DVT afflicts nearly 2 million American lives annually, of which about half the folks will go on to experience a pulmonary embolism, and actually kills more Americans than AIDS and breast cancer in aggregate. Here you see some of the risk factors, and these risk factors include congestive heart failure, cancer, respiratory failure, infection, age over the age of 40, previous hospitalization. Acting Surgeon General is Dr. Stephen Galston, and he actually has now a call to action surrounding VTE. This is a study that really looked at over 67,000 patients at 220 hospitals and looked at those folks that did not have a venous thromboembolic event in comparison to those that did. And you see a nearly doubling of cost, and a lot of that doubling of cost came within the length of stay increase. DVT has significant readmission associated with it, and the cost of the readmission is 21% higher than what it was on the initial hospitalization.
This is from the Glory Registry. I was one of the authors on this paper, and what we found was that if you look and see how often the appropriate prophylaxis was provided, it was relatively small. It was only 47% of total hip replacements and 61% of total knee replacement patients. And what's more disturbing is that this was a Glory Registry, so there was 100 hospitals, many surgeons who had an interest in DVT prophylaxis. And if the experts couldn't get it right more than 50% of the time, what's that say for the general population? Which guidelines do you follow? These are the ACCP guidelines. These are multi-specialty. And of course, these are just guidelines. The importance of risk stratifying is very important. These are not DVT guidelines. They are guidelines for pulmonary embolus. And the two pillars of these guidelines are risk of major bleeding and risk of PE. And my problem with these guidelines are that it's very hard to define when you look at the patient in the preoperative area to decide who's at a risk for bleeding. The ACCP guidelines are very strict. We recommend against the use of aspirin. Risk stratifying should take place no matter what you do.
The 2008 American College of Chest Physician Guidelines has shown us clearly that thromboprophylaxis with a low molecular weight heparin, unfractionated heparin, or a factor X inhibitor are all considered grade 1A recommendation in the acutely at-risk medically ill patient. We looked at over a 3.5-year period, we looked at almost 200,000 patients, 196,000 discharges across 227 hospitals in the United States. What we found was that about 2/3, 66% of patients that were discharged from U.S. hospitals actually did receive some form of prophylaxis while if they were considered at risk for venous thromboembolism. But when we asked the question about whether they received it appropriately, based on our definition and based on comparison to evidence-based ACCP guidelines, we found out that it cut it in half. Only about 33.9% of patients actually got appropriate prophylaxis. The risk for venous thromboembolism following hospital discharge has been estimated both in the medical and surgical population to be on the order of 2/3 or 67%. Now it does drop down as you go to the second 30 days or so post-hospitalization down to about 20%, and then in the next 30 days between day 60 and 90 it goes down to about 10 to 15%. 50%, but it doesn't go down to zero. Enoxaparin is a leading low molecular weight heparin for the prophylaxis of DVT, which may also lead to pulmonary embolism. And the landmark study published in the New England Journal of Medicine, LOVENOX, which compared enoxaparin compared to placebo, showed a statistically significant reduction in venous thromboembolism by doing something or giving the low molecular weight heparin enoxaparin. It showed a 63% relative risk reduction with the number needed to treat of 11. The PRINCE trial looked at enoxaparin compared to unfractionated heparin and showed a relative risk reduction of 19% on the side favoring enoxaparin with the number needed to treat of 50 compared to unfractionated heparin. The safety profile in LOVENOX looking at enoxaparin compared to placebo, one sees that the risk for both minor and major bleeding were not statistically significantly more using enoxaparin compared to placebo. In the PRINCE study, when you look at the side effect profile of enoxaparin compared to unfractionated heparin, you'll see that in equal number of patients in both arms, sees that the bleeding complications, both minor and major bleeding, was significantly less in the enoxaparin arm compared to the unfractionated heparin arm. Hematomas were less, as well as mortality or death was less in the low molecular weight heparin arm compared to the unfractionated heparin arm. The ACCP guidelines recommend that one should give appropriate VTE prevention, and I would make the argument that today in 2009 we have medications that will allow us to manage our patients appropriately. What we need to do is change our culture in terms of ensuring that not 1/3 but over 99% of our patients receive appropriate VTE prevention.
I'd like to thank Dr. Al-Peshamin, Dr. Fred Kushner, and Dr. Stephen Deidelsweig. I'd like to summarize those three wonderful talks right now. Up to 2 million Americans suffer from DVT annually. Approximately 300,000 patients die from PE each year, with most cases resulting from DVT. And as we see, the economic consequences of VTE may have a substantial impact per patient. And despite the guideline recommendations, appropriate DVT-PE prophylaxis is lacking in hospitals. There is a need for risk stratification and DVT-PE prophylaxis in appropriate patients throughout the healthcare continuum. And this includes patients who may remain at risk after hospital discharge. We also see that appropriate DVT-PE prophylaxis includes completing the recommended course of therapy, which is so important, and the approved length of therapy with LOVENOX given to acutely ill medical patients is 6 to 11 days and was administered up to 14 days in LOVENOX.